My presentation this afternoon has a couple parts to it. We would like everybody to sit in through numbers 1 and 2 here because it kind of pertains to everybody. And then if you are implant faculty or you wish to stay and hear what else I have to say, you're more than welcome to. So it amazed me over the course of this past year how many times something that seemed to me to be fairly straightforward needed to be explained and re-explained to students. Hence this paper that was in the back of the room for you to look at. What I tried to do is, in as clear language and as explicitly as possible, explain every little detail in the process. So hopefully there shouldn't be further questions. And the reason that all of you are here is that there are a lot of these patients in the clinic, and even though you may not be actually doing the implant procedures, you are more than likely going to be treatment planning patients who are going to need implants, and you need to have a knowledge of how the referral process works. So you're all probably as sick of getting memos as I was of writing them, so hopefully this will end most of it once and for all. So the reason that we get so excited about following a policy in terms of the referrals and how we treat patients is because this process is kind of unique compared to the other things that we do at the school. A lot of fingers are in the pot, a lot of different departments are involved, multiple students are involved. It happens over the course of years sometimes, and so it's really important for us to have a handle on moving these patients through in an expeditious way, making sure nobody slips through the cracks, making sure now that there are requirements that students kind of get to share in the patient load. So that's why we kind of harp on this. So the first section outlines what constitutes an acceptable pre-doc implant case. And basically single posterior crowns, mandibular overdentures, adjacent posterior crowns we are allowing under controlled circumstances where the student who owns the patient will restore the first unit and then share the second with another student. And in exchange for the added treatment time, the patient's getting a substantial discount by being able to be treated in the pre-doc clinic. I think it comes out to like $1,000 a tooth, so it's worth their while to do it this way. And if they don't want to, they certainly can be treated in post-grad and pay post-grad fees. Implant restorative faculty. These are the individuals who will be signing off on the implant portions of the treatment plans, assist in ordering parts, checking off surgical guides, following through all of the restorative procedures. And the reason I made a point of saying that these individuals are restorative dentists, prosthodontists, general dentists who do this stuff a lot is because we often have situations where surgical guides are being made with surgeons and not getting checked by restorative dentists, the wax-ups and these sorts of things. So kind of important that we're keeping tabs on that. The list is updated. We add people leave our programs. We have most years an implant fellow. This individual usually has a pros background and is doing an additional year and getting more surgical experience. Sometimes we get surgeons who are trying to get more pros experience. But based on that individual's knowledge and experience, he or she may or may not be implant faculty as well. And actually this year it worked out very well. We had 2 of them, and they had office hours where students would sign up and make their surgical guides with them. So that was very helpful. So the workflow of patient treatment. I like to think of it in simple terms, meaning you treat them all the same way, all right? It's a patient who's coming in missing teeth, and you always start in the same place, gathering the same information, and that patient may or may not evolve from there into an implant patient. All starts with developing a treatment plan, and that's where you guys will come in. You may determine that, for instance, a single missing tooth is best served by placing an implant. There may be other restorative needs that you'll be signing off on. And at the end of the day, you need to come up with a treatment plan. And that treatment plan has to include those procedures that are associated with the surgery and restoration of the implant. And there are copies of kind of sample treatment plans in the back if you're interested in all of the things that have to be itemized. But if you're not implant faculty, this is where you want to get the assistance of somebody that is, because they have a better handle on what's supposed to be placed in the treatment plan. So still have to sign off on a restorative treatment plan. If you're not implant faculty, then you get a consultation from someone who is, who will kind of co-sign that portion of the treatment plan with you. And it always comes up the question where it seems like it's an implant case, but probably not a pre-doc implant case. What do you do with the patient? It really depends on the circumstances. If it's a very straightforward kind of patient in terms of their other restorative needs, in other words, it's clearly an otherwise pre-doc patient, then that patient will stay a pre-doc patient and will be referred for the restoration of the implant upstairs. But the referral pattern is the same, all right? You're going to come up with your treatment plan. You don't necessarily have to itemize the stuff you're not going to be doing. It would be good if you could, with the implant faculty's help, come up with kind of a ballpark of what a patient can expect to spend for that treatment. And again, we're talking about something that's going to be very straightforward and routine, all right? A single central incisor, for instance. In those kinds of situations, the patient stays the pre-doc student's patient, still takes the patient for a screening with Dr. Andriana, but at that point, SEB will assign that patient to the appropriate postgraduate clinic for restoration and surgery. If it's the other kind of patient we sometimes see where there are multiple missing teeth, or a quadrant of missing teeth, and there are a lot of other things going on. Well, clearly this isn't going to be a pre-doc patient to begin with. We don't even know if implants are in play because there's so many other considerations, and it's not our job to make that on the pre-doc clinic floor. So under those circumstances, and I mean, you have a feel for what kinds of patients should be treated downstairs and which should be referred, then you're going to refer. You don't need to worry about trying to come up with a treatment plan. It's not going to be our responsibility in the pre-doc clinic to decide that, determine it, or do the treatment. Any questions on that?
Sorry, I always have questions.
That's okay.
How about if we have a situation that the only thing the patient needs is implant number 8?
Well,
No other restorative needs.
probably shouldn't have gone downstairs to start with.
True, but it is with the, let's say, sitting with a senior or a junior student. Are we supposed to refer it at that point to the PG clinic, or?
I don't know what the best answer to that is. Really shouldn't have ended up in the pre-doc clinic to begin with. Anybody have any thoughts on that?
Yeah.
Seb's not here. Right?
Because it happened last year with some seniors. I think they, if they got your approval because you're the cross minor, if you approve that, they can do it.
I don't think we had any anterior restorations done in the last couple of years in pre-doc. I mean, there was a case a few years ago, but nothing real recently.
Are cross minors allowed?
Minors?
I haven't done any with, I mean, if you have a case where you want to do that with a student, then that's fine. I haven't experienced that recently myself.
I think she would have to determine, no? I mean, don't you, you're the gateway for the cross minors.
I am, but if you're the person who's going to be working with that student, it's ultimately your decision if you are comfortable walking them through that.
So it's not very often.
I'm not.
It has happened. I know, because I didn't participate, but I know that it happens.
I have seen those referrals both ways. I have seen, say, somebody wants implant number 8. I have seen the pre-doc take it up for evaluation with Dr. Andriana, and he will decide he wants to send it to 8, which is D usually, or cross. And I've also seen it go directly to cross because it's number 8. So I've seen it go both ways.
I don't have a problem doing it either way, and I think the decision would be nice, because then it's...
I mean, I would say,
that.
if the student, it's a requirement for them to work up a patient to present to SEB. And I would say if that student hasn't done that yet, then go ahead and let them have the opportunity to do the workup and see the patient upstairs. If it doesn't make sense to do that, then refer it upstairs. Anybody else on that or anything related? Now, something that's a little bit different is we have a few patients who are referred to the dental school expressly for implant treatment. Those patients go to SEB first for screening and then get assigned either as a pre-doc or post-doc case. So if one of these patients ends up in the pre-doc clinic, just like any other patient, I would give them a comp oral. If you find other treatment needs besides what the patient is there for, you should document that and contact the provider to make sure that that's followed up on and inform the patient. If it's a situation where you don't feel that the implant is the preferred solution to the patient's issues, I guess I would talk to Seb about that, because he's kind of the intermediary between us and the outside world with regard to that. Any questions on that? I don't know that that's come up, but...
What does that mean? If the outside provider sends here only for implant and they're not going to do the restorations on it?
Sometimes we do just the surgery, sometimes we do both. So Seb hashes that out when he screens the patient. These patients come directly to him first, and then he makes the assignment. So, as with any other patient, we need to sign a treatment plan in Picasso, and that can be any of you guys. If there is an implant component to it, you should have your implant faculty co-sign that portion of it. The implant faculty will then swipe a referral to pre-doc implant, and that's how the patient gets to see Seb, and also signs off on the paper implant screening form. And then once these 3 items are completed, signed treatment plan, the electronic referral, and that screening form signed off, patient can then schedule with Lynn or Hati on the 3rd floor for that implant evaluation. So every patient that needs an implant originating in the pre-doc clinic, other than those there from the outside expressly for that purpose, has to funnel through Seb first. You don't have to worry about making a referral to any surgical entity in the school. That's not our decision to make, all right?
Jen?
Yep.
Maybe I missed it. We should not be making direct referrals to AAGD.
Correct.
I just have a question. Today I screened a patient that the patient referred from pre-doc clinic. The patient needed 29 or 30 implant. But the patient was not informed that there will be price difference. So
It was referred directly to Pros and not to Dr. Andriana, is that what you're saying?
no, the like implant referral was made by a pre-doc or like the implant faculty.
Right.
So the patient doesn't have money to for those 2 implant restoration in PG Pros area. So even before they refer to PG Pros, is there any way to discuss with the SEB first, so he can find a way to do it in the pre-doc?
My question is, how did the patient get from the pre-doc clinic to you?
Electronic referral?
Electronic, yeah.
Okay, see, that's what the problem is. The patient always has to go to Seb first. And Seb has the conversation about the finances with them and determines, yes, you can be treated in pre-doc, these 2 adjacent teeth, these are the conditions under which we'll do it. This is how much it's going to cost. If you don't want to do it that way, then I'm going to refer you to a post-grad clinic. See, that's why one of the reasons why it's important to go through him all the time, because he covers all that stuff. The patient knows what to expect in terms of the surgical fees, in terms of the restorative fees. He's the one that will confirm that it's a suitable pre-doc case. There's a lot of, it avoids a lot of problems by doing it that way. So I guess to get back to your original question, we should probably talk to that pre-doc student who made the referral to get things going to see Seb, and then we can kind of hash that out.
It's not unique just to the implant
Yes.
program. Many times a patient is referred to a graduate program, endo, perio, whatever. It's incumbent upon the referring student and faculty member to discuss with the patient that the fees are going to be higher. We have them, they're available to look at if you can find them on the fee schedule online. I mean, it'll tell you what the postdoc fee is. So the students need to get into the habit of discussing that with their patients, and the faculty have to make sure that they do, because that does happen.
Sometimes they are told, okay, and then we tell them, if you stay in our group, we're going to extract so many number of teeth, and we're going to give you a denture. If you want to save your teeth, you will have to go to postgrad, the fee will be higher. The next thing is we see is the patient is back in here because they don't have money.
Well,
But then
you
I
have to
say
extract
is,
the teeth.
yeah, we're going to lose all the teeth, but they said, so I
No.
said no. So I have a right
I know
to
it's difficult.
refuse.
You can. I mean, I know it's a difficult thing. Many
Yeah.
times
They
they
come
want to
back
come
and
back
forth all
down,
the
have the
time.
same treatment plan
Yeah.
that was going to be done in PG, and then we get into big problems, and the same thing if it happens in AGD, if it goes from PG. So it's
So
one
if
of
we're
those
gonna,
things.
if we think a case needs to be treated as post-grad, we're still gonna submit a referral to Dr. Adriana. We're gonna say, submit it as a pre-doc implant case or a
No, you just
Postgrad.
Post-grad implant. And this is assuming this is a simple,
simple.
straightforward, not,
What if the patient needs to comprehensively be treated at a post-grad?
then it goes to post-grad pros or AEGD.
I see.
Because it might not be an implant, might be.
If there are too many other things going on to allow you to make a very simple decision that's a suitable case, then you
I
shouldn't
think
be
if-
messing with it.
If I may, if PG Pros decides it is not, that it could be an AGD case, they can make that referral back to AGD. It shouldn't go the other way around. It should always go to PG and they can refer back to AGD. It's just handled in that way. I think you will eliminate a lot of planning, go that way. You get first dibs. We have quota requirements for certain things.
But how
PG Pros.
soon, but
What?
how soon pros can see those patients if they have to wait for other
That's
appointments?
correct.
We've heard it sometimes months and months when before somebody calls.
Then you have to talk to the.
You see the same thing in AEG, though. They have the similar backlog.
It cycles. So if there's a case that needs particular attention, maybe the student needs to walk it up with the CATs and the x-rays to the PG director. And there are some times when we would like to be involved more in the screening, the original screening program for those things. And that's something that gets tossed around. Sorry.
I
to
would think
sidetrack.
that now is the waiting list, the very soon. I'm screening patient before by previously.
I've had patients screened the same day. I brought them up and they were screened to PG right away.
All right, so try to keep it simple. If it's a pre-doc student, go straight to SEB every time, unless it's already been to see SEB. If it's something complex, then it goes to a post-grad clinic directly, okay? So if it's a pre-doc case, the student has worked up the treatment plan. He then presents the patient to Dr. Andriana. He will then make the final determination that, yes, it's going to be treated in pre-doc. He'll go through the financial stuff with the patient. He will then, he's the one in charge of distributing our surgical cases among all the programs in the school that have to do implant surgeries. So that's another reason why it gets funneled through him. And then, as I mentioned, if it's a patient referred from the outside specifically for implant treatment and nothing else, that patient has already seen SEB, and that screening then is bypassed. And this says what I just said, I think. So he will verify that it's a pre-doc restorative case or refer to the appropriate post-grad clinic for restoration. He will make the surgical referral. And he is the one that's going to enter that U0182 code that was in a recent memo. The reason this is important because this is a requirement for the students now. And they have to realize, and we have to be cognizant of the fact that this is a code that he's the only one who's able to use it, and it's up in the implant center. I know myself, when I'm in a hurry signing off patients, swiping through patients, I don't always pay attention to what's being charged out, but we ran into circumstances over the past year when this was a requirement for the first time where students would have, 3 or 4 of these for the same patient. It was because they were having consults in the pre-doc clinic and they would be signed off by multiple faculty, and they only got credit for the one that was signed off by Dr. Andriana. So that's why that's kind of important.
So the faculty gets the salmon slip.
No, no. I almost accidentally signed one a couple weeks ago. And I said, no, this is not what we're doing. Okay, so patient is then assigned to a surgical resident. The student meets with that resident and discusses what kind of surgical guide to be made. And hopefully the surgery, and this is a bad time of year because patients are being transferred from one student to another, and you need a little time to catch up with things, but we would like the surgery to be scheduled within a reasonable amount of time so that the student can get the guide done and have the opportunity to try the guide in and be supervised doing so. Now, this is another issue that we had was students having surgical guides signed off, subcode 9, by perio faculty, by surgical residents, by whoever was convenient. And really, we need to be checking that the guides fit. We should be having the students take radiographs to make sure they have things aligned properly. And I know that the timing of things sometimes is such that you can't avoid trying it in conjunction with doing a perio recall, just for the patient's convenience. But the student should get one of us to come over, verify that things fit, and even though we're not going to be the ones swiping the student out, we should at least make a note in the chart saying, guide tried in, blah, blah, blah. And so that when I go and see when I'm checking requirements that Dr. Schifferle signed off on a surgical guide, I can go back to that chart and say, okay, it was checked appropriately. Any questions on that? And then at that point, if the student is available to attend the surgery, he may assist if he's not on rotation. And after the implant heals the appropriate amount of time, the student begins the restorative phase of treatment. The surgical residents are not always good at taking a radiograph prior to releasing the patient for restoration. That really should be done, and if they don't do it, we should do so. And at this point, the restorative implant faculty will need to assist the student in ordering components for doing fixture level impressions. And this is another thing. Students, I'm going to go over in a few minutes what the students are getting didactically, but the current D4 class will have gotten a very explicit and extensive lecture by me 3 times on this whole process. So they should know that they have to see you ahead of time to order the right parts before the patient comes in. There really shouldn't be anybody coming into clinic with a blank look on their face because they've gotten it, as I said, at least 3 times. They can pull up the PowerPoint lectures. There's really no excuse for them to be unprepared. So order forms for any components go to Deb Falter in room 215. If it's something that can be reused and is in good shape and can be sterilized, it should be returned back to her. She's keeping an inventory of spare parts, and it should be labeled.
Question? Question. The beginning of the previous slide, you started after the appropriate healing time. Shouldn't there be a note in the chart from the surgeon that the patient is ready for the restorative phase?
Yes.
It's missing 90% of the time.
Well,
My humble experience.
we should address that then, and the x-ray thing. So I'll add that to my list of notes to surgeons. We need to talk to them about the surgical guides also. Anything else?
If you do get the patient, we do have a radiograph and there's already some bone loss.
We'll get to that in
Okay.
part 2 of the presentation.
All right.
Okay, so restorative procedures are to be supervised by implant restorative faculty, and it's obviously preferable that the person who signed off on things from the start be the one to follow things through, especially if the case has been transferred between students in different classes. If it's a situation where there are multiple adjacent implants being restored in the same patient, same faculty should supervise that so that it occurs in an expeditious way. Their clinical requirements, there are 3. The first is that implant evaluation, so they have to do the diagnostic workup to present the patient to SEB. It can be a patient that they don't treat or who decides not to have treatment done. All right, it's the process of the treatment planning that they have to go through. The second is an implant surgery assist. They have a number of opportunities to do this. There's a rotation in the D3, D4 year where they will spend a day assisting implant surgery. They also may assist in their own patients' implant surgery if they don't have to be somewhere else. But we had some issues last year with, I think one student had 17 implant surgery assists, and in the process didn't complete a number of other requirements. He needed to graduate, but it's not a large room, and there are a number of people that have to be in there. The student who's on rotation and the student who belongs to the patient have priority, all right? And if there's room in the room and the student has nothing else to do, they can attend if they're interested in watching the surgery, but after they attend to, they're not going to get additional credit for that. And then the third item is to make a surgical or radiographic guide. The other requirement that we ask of them at the end of the D4 year is they turn in what's called an implant portfolio, and basically it's documentation of the cases that they've done through dental school. Whoops, I thought I had that in here. Maybe not. And basically it gives them the opportunity to document the workup that they did for their implant evaluation, some comments about the fabrication of the surgical guide and you know, what were important considerations in doing that, items about the implant surgery that they assisted, and then there's an optional portion about restorative procedures that they did, and it's optional because not everyone gets to do that. So if they do a really good job on it, it's worth up to 5 points toward their CLD 842 grade. It is possible, and it did occur, that students filled out the portfolio and got 0 points because they just, you know, kind of filled in the blanks without any thought. There was an issue of students submitting radiographs and photos with patients' names on them, and they're told explicitly not to do that. So from now on, they're going to be docked for that, for HIPAA violations. Any questions on any of that?
What percentage of the students have restored one or more implants?
I don't know off the top of my
By the
head.
time
Do you know?
You know that?
From the graduating class that just left, I would say half.
Half?
Ballpark without, adding.
I think it's probably more than half.
You think more?
And it's more than last year. I mean,
Yes.
it's-
Oh, yes, it grows. It's grown every year.
I should also add that all students, the graduating class that just left had 1 year to meet all of their requirements, and I think all but maybe 4 did so. Those that didn't have a patient to make a surgical guide for, I created an exercise for them so that they could do that. But not too bad having just 1 year to complete everything. Okay, part 2 is the implant tracking and complication form, which is also in the back for your reference. This kind of started, maybe Dr. Monaco would like to say some more about it, but it kind of started out as a means to track complications that we see in the school and correlate it to different factors. And also kind of evolved into a way to document all the pertinent information about the surgery and restorative components. As you know, in practice, if a patient comes to you from another practice and they've had an implant placed somewhere else and you have to replace something, then you have to go chasing down that individual's other dentist to find out the particulars about the implant. This gives us an opportunity to have that documentation in one place, so it's very easy for us to locate it and give it to the patient. So my rendition here is not as good as what you see in front of you, but basically there's the first side of it is the tracking form. The first portion of that is information about who is involved in the treatment, the surgical resident, the supervisor, restorative resident or student, their supervisor, whether it came from private practice, and then information about the implant. And one of these should be filled out for every implant placed. So it tells the tooth site, the manufacturer, size, reference number, lot, etc. And then there's a place where the surgeon or the resident is going to fill in the particulars of the procedure itself, the date, the circumstances, if it was immediate placement, early delayed, surgical guide used, what kind of flap management there was, medications that were prescribed, whether there's a graft, and if so, again, documenting the material that was used. The second half of that first page is for restorative information, and so that's something that those of us who are assisting in the restoration need to be aware of. When we complete a restoration, we need to be filling out information about the abutment that we use, for instance. And again, there's a place for the type of abutment, size, reference number, lot, etc. All right? Side 2 is for complications, all right? So getting back to Dr. Brewer's comment about bone loss, that's one of the things that we're looking for. And there's a place, I think it was on the last, yes, there's a place on the form that asks the osseous levels at the time of restoration. So we take a radiograph if the surgeon has not done so, and if we see that there's been bone loss since the implant was placed, well, that becomes a complication, and then we need to turn the page over and report that on the other side.
Jennifer?
Yep.
Sorry, on the other page it says type of abutment, interim, prefab, or custom. You could have an interim and the other.
Yes, that's true.
So, like, what do you?
You would put them both. So the first section is for the post-surgical or biological complications, whether there's a problem with positioning, paresthesia, infection, periimplantitis, perimucositis, bone loss, graft failure, insufficient attached tissue, and other. So this is where if you see bone loss on recall, or your student has a patient in for perio recall, the patient had an implant placed a few years ago, and you see when you're updating the implant, the radiographs, that there has been bone loss. Again, this is when you report that.
How often do you want the x-ray? At recall for implants?
We haven't ironed that out yet. There's also a section for prosthetic complications, issues of screw loosening. A lot of these we tend to see more upstairs, but we could see them downstairs. What we do see often, and again, this is why all of you are here, not just the implant faculty, is you may find during, again, a recall exam, you're taking bite wings and the crown's not seated, or the patient's complaining because there's an open interproximal contact. This is where you would document that. And then there's a section for patient-related factors. And then, most importantly, at the bottom, it's our plan for treatment, all right? Who's going to follow up on this? Well, probably if it's a case of a biologic issue, and it's an implant that was placed some time ago, in other words, it's not an immediate surgical follow-up, I would look and see who did the surgery, and if that patient happens to still be assigned to that individual, that would be a logical place to refer the patient. But if the patient's not assigned to somebody, I think probably post-grad perio would be the appropriate place to send the referral to. But we need to put down what our recommendations are, refer to post-grad perio for follow-up. There's a place where you would fill out the student's name and signature, your signature, and then this all has to be written out, obviously, in the progress notes as well. There's going to be, at some point, hopefully soon, a U-code that's going to be tied to any kind of implant complication, and again, that's to help us in the future be able to automatically access this information. And then the original form will be kept in the chart, and a copy is going to go to Bonnie Berry, whose office is now around the corner down the hall here. And this is to help us ensure that things are followed up appropriately. Any questions on that, or Ed, do you have anything to add?
No, I was just wondering in my mind about cross-referencing patients to databases, but we can do that by either the implant production stage we have, Picasso, or the surgical restorative implant production. So if you have it in, if we keep these forms in alphabetical listing in Bonnie's room, you can always find out if you're interested in the implant. Picasso entries are by patient names, so if we continually keep track of those, we can cross-reference it if we have to an implant tracking form and get all the information that you have to get. Not too much work.
So again, a number of you may peripherally become involved in something like this, so please know that it exists. It's just beginning to be implemented now, but there will be patients who have been treated in the past where there unfortunately are likely to be problems, and so you may need to, we'll have the forms down on the clinic floor to be filled out. Any questions on any of that?
We discussed this earlier in the clinical presentation by Joe. And one of the things that's going to be hard to do is to make sure that the restorative entries get placed. Surgical entries should be placed at the time of surgical placement, but it's up to everybody else at the time of the restoration to make sure that there is a restorative entry made. And that's going to be a big, a very difficult thing because we're going to forget it and there'll be a lot of other things that come into play. But every time an implant's restored, one of these sheets should be filled out indicating the type of abutment and all the other information.
Well, this is the point where if you don't really need to be here, you don't have to be. If you're not implant faculty, I won't feel insulted if you leave.
Can you talk about all the different copies?
We did talk
It's supposed to be copy in the chart, copy with coordinator, and copy with Bonnie. But every,
Last I heard-
it's like sequential completion of the form,
The
you
form
know?
in 3 parts.
It's a double-sided form.
So we just, I'm just confused how we go about getting copies at every time we make an entry. And then you
I don't understand what you're making. I don't understand what you're.
Okay, it's supposed to be a copy in 3 different
You have,
places.
yeah.
The chart, Debbie, Bonnie.
I think just Bonnie. Is that right?
Well,
Or is it given back to you again?
On the form, it says 3 copies, one this, that, at the bottom of the page.
We're trying to consolidate it with Bonnie, I think. Is that correct?
we are. The last I heard, it was just going to come to me and not Bonnie.
Right.
Okay.
And Bonnie can get it from me when she needs it.
So
Okay.
it's not in the chart?
It's the originals in the chart.
The original's in the chart.
One copy to me.
Okay.
But
That's it.
the original isn't filled out all at the same time.
I understand that.
So what do we do?
I don't know.
Okay, all right, that's what I want to know. We don't know, so we have to figure that process.
Yeah.
Well, you're going to date it when you note the complication.
Definitely. And then, so then do we have to make a copy of that to give to her? That's
Yes.
what I want to know.
Yes.
Or do we,
Copy of the chart?
The original stays in the chart.
okay, it's just a step for people. It'd be really nice if it was electronic.
It'll be nice when it's electronic, yes.
Okay, so that's, it's our responsibility to make a copy of the form and get it to,
But only with the complications, correct?
No, tracking.
Oh, so that means we are making 2 copies. If we finish restoring it, let's say, the
that's what
moment
I'm
when I
saying.
submit
Every
the
time you
crop.
change the form, you gotta make a copy.
Yeah, I see what you mean now. I would say, I mean, does it make sense to not give a copy to Deb until the whole page is filled out when the restoration's done?
No, because what if there's a complication before that?
I'm not talking about complications, I'm talking about just the documentation of the implant itself.
Okay.
Smoothly.
But if you, I guess if you have a complication, you're not gonna restore it yet. Is that,
That's-
Ideally, maybe the form could be submitted as made out. And if they're put in alphabetical order, they can just be stapled together, that's all. So that you have a patient family, a marriage of all the forms, and then they can be kept together.
I don't think there's any other way with paper
Or not
copies.
with the paperwork, it's a bit of a nightmare, so every time a form is required to be filled out, it would go back to the collection point, the reservoir where they're collected, and then if they're placed in alphabetical order, you could just pull out the original one and staple these to the original, and then everything would be kept together. Then we wouldn't have to worry about double-sided forms, which are good things, but it's a nightmare to do this, just a kind of a nightmare, but it's important that we track the implants. And patients come back to us, and they know what implants were placed, what lot they're from. If a company ever had to recall something that we put in, it'd be a nightmare. We can't track anything, not one single thing. So,
Could you put it all on a single-sided form with, like perforated or whatever, so that the first part, the copies tear off and go to the other?
I think it's a good idea, but I think it's going to have to evolve. Right now it's not there. Yeah. I think we have to see how this works or how it doesn't work. Then as that evolves, and then to refine the forms. Yeah. But it's not a final document, obviously. And as I said, the big hang-up are the restorative components. We're going to forget to do those. Surgery guys can do it at the time of surgery, and the tracking for periimplantitis and mucositis can be done. It can be easily done, but people will be alerted to that, but they're not going to be alerted to the restorative components of the document.
Oh, they have to put that.
That's been the
required in the chart.
No,
See,
yeah,
that-
like for some of the abutments.
I don't know if the abutments have stickers.
No, they don't.
They don't have
So
stickers.
we can, but there's information.
Sometimes they do.
They should copy it.
There, yeah.
I kind of just was going to ask about the stickers, because some of the abutments, even though it's not a sticker form,
Yeah, but
but there is something which you can glue to the chart.
yeah.
Now, does this go to the progress notes, or it goes to the implant tracking form?
I would put it in the progress notes, just
Okay,
because
and
that's,
just copy the information
Yep.
to the tracker.
yeah. Anything else?
See how it works. I
Well, I
think.
could see how it works and, get it done for on the waiting list.
Well, the restoration part's easy. Okay, I just want to quickly tell you what the students have in terms of background. Beginning in their D2 year in the spring semester, they have their first implant dentistry course where they learn kind of foundational concepts, general restorative concepts. During the early fall, then they have a laboratory course where they learn to make surgical guides and make impressions, kind of, play with the parts. In the D3 fall semester, They have RDN 831, and this course emphasizes more the surgical concepts, but starting last year in August, I added a lecture to kind of outline the whole process for them. So that's the first time they get it. In the spring, in Donna's fixed course, she added a lecture on both treatment planning and restoration of fixed prostheses on implants. And I tried to emphasize clinical procedures and how they differ from treatment of teeth. So that's exposure number 2 for them. In the D4 year, in August, they're going to get a review during their orientation week. And so by the end of August, every D4 student really should have a handle on what they're supposed to be doing. And then, of course, there's an elective that they can take in the second semester. So again, we talked about the clinical requirements. I'm not going to go through that again. The D3 year, they have a implant dentistry clinic in the spring semester, and they need to make 10 CPUs of the requirements by then, and then the rest by the end of their final year. And these are cumulative, by the way. They can, I just had a student email me. She had made her requirements by the end of her junior year and wanted to know if she had to do another 35 senior year, and that's, no, she doesn't. So again, these are processes associated with restoration, and the ones highlighted in yellow are the ones that are required. The restorations themselves, they get credit for within the other disciplines, fixed or removable. And again, the 3 procedures where they have a requirement. I'm going to go through it again. When they do a implant surgery assist, or if they do a lab exercise for me to make a surgical guide, they have to fill out one of these AAF forms to get credit in Picasso. I mentioned the RDN 845 in D3 year. I mentioned the portfolio contributing up to 5 points toward their spring semester CLD course. And the implant portfolios were kind of interesting to see what students would do. Some of them did a really nice job on them, really put some thought and preparation into it, talking about treatment planning options, talking about factors important in the fabrication and surgical guide, talking about how during the surgery the surgeon didn't use the surgical guide, but that's another issue. Talking about restorative experiences. So I actually got quite a bit of information in terms of what students are doing and what they're doing in other clinics. There's the portfolio form. So basically, they can either just fill out 1, 2, and 3, get 0 points for it, but they've met their requirement. But hopefully, most of them did a much better job than this and had a little bit of discussion. And this is posted in the CLD syllabus if you're interested in looking at it more closely. So patient treatment, and again, we talked about this at length. We're going to treat every partially edentulous patient the same. We're going to do the same things for all of them, same radiographs, same problem list, mounted diagnostic casts, come up with a treatment plan. And again, these are the ones likely to be treated in the pre-doc clinic. Routine single posterior units or two adjacent posteriors. Also did a fair number of mandibular overdentures this past year. So under these routine circumstances, you're going to be completing either co-signing the treatment plan or signing it if you happen to be the one supervising. And then your referral will be to pre-doc implant. If it's a restoration not likely to be done in the pre-doc clinic, yet all of the other patient's treatment needs are routine, the patient is going to be referred to post-grad implant referral, and that will be a limited assignment for the restoration of those teeth only. The student hangs on to the patient to do the other routine restorative needs. And if it's a patient like this who wants an implant to replace number 30, and you take a look at this, obviously you don't need to sit down and come up with a treatment plan. That patient will go straight upstairs to PG Pros.
If they have a lot of money.
If they have a lot of money, and if they don't, they're going to start losing teeth. Got to simplify if we keep them downstairs. So one of the things that is important in the treatment planning is communicating to the patient what the fees are. The students will all include a cone beam fee, whether we do it or not. We may or may not. A fee for the surgical guide, possible graft, implant, the surgery itself, abutments, and then the restoration. The graft and the surgical placement are going to be post-doc fees, and the students always get kind of flustered because the Picasso doesn't allow them to enter the surgical placement because they're not going to be doing it. But if they go under provider and click on the asterisk that shows up, it'll bring down a pop-up menu where they can select post-grad implant, and then it will allow them to enter the fee in. So again, the workflow is you make your diagnostic evaluations, you develop a treatment plan, you sign, you meaning the implant faculty, the implant referral and screening form. The patient then at that point can have their implant screening, at which point then the surgeon is assigned. So again, no direct referrals from pre-doc clinic to anybody to do any surgery. Unless it's an extraction in an emergency. This is the implant screening form, so the student's going to fill out the top part of that, what the intended restoration is, and the implant faculty will sign at the bottom under the restorative treatment plan. We talked about the eligible cases. This is from a lecture I think I gave in Donna's course, so they should know indications for single tooth implants versus other things when you're talking to them about treatment planning. We talk a little bit about screw versus cement retention. I tell them that yes, screw-retained restorations are retrievable, but they're kind of harder to try in, unscrewing and putting it back and forth. The placement has to be much more precise, so the screw channel isn't coming out through the labial surface of the tooth. And mainly here, we do them when there's limited interocclusal space. So how much is not enough? Well, our shortest prefabricated abutments are 4 millimeters, and if we're talking about placing a finish line at about tissue level, you're going to need, that means, about 6 from the finish line to that occlusal contact if you're going to put porcelain on the crown. So if you have less than that in terms of space, you're probably going to be thinking about doing something that's screw retained. We talk about cement retention as being what we typically do here, a lot more forgiving in terms of angulation of the implant, more straightforward clinical procedures sometimes. We talk about surgical guides and the purpose of doing the diagnostic wax up and making the guide, allowing the surgeon to center the implant under the tooth. In a case like this where the space is wider than the tooth is going to be, you want to tell the surgeon where the diastema is going to end up. You want to center it for them. In terms of what they're taught to make guides, they need their mounted casts, they need to look at their radiographs, they need to wax up the missing tooth. They may or may not do bone sounding depending on the circumstances. They'll duplicate their wax up. And then I'm not sure what the thickness of the surgical guide material. Do you know, Costas, what the thickness is?
We use minimum 1.5, usually use 2 millimeters.
2 millimeters?
Yeah.
That's really thick.
That's what Dr. Buhai at the Adriana recommended, but
That's what we're using in Beijing or with the
with the pre-op.
Oh, this is in inches. That may be why it's not, yeah. Yeah, okay. The stuff, yeah. All right, so this is the stuff we happen to use in our office, so that's 0.1 inches. And I don't know off the top, oh, here, 2.5 millimeters, okay. So this is something that they've been doing with the implant fellows because they don't have access to the Vacuform device that they need with that more rigid material. So that's why our implant fellows, like Costas, have been so helpful. So they're taught to trim this more rigid material about to the CEJ. They mix their PMMA and go back to their pre-op cast. They load it. They may add barium sulfate if it's also going to be a radiographic guide. Place it in the pressure pot, retrieve it, trim it, and then using their radiographs and looking at the casts and the roots of the adjacent teeth, they determine what the orientation of the implant should be. And they'll drill a hole through there. They might place the rod in the stone itself or just sticky wax it in position and then backfill some PMMA to keep it in position. And then we like the students to talk to the surgeon to get a feel for what kind of guide they want to use because we want them to use it, all right? If they want just something like this where the sleeve is removable for their pilot drill, that's fine. Some of them like a buckle slot also. And some of them would like more of a V cut into the guide. So it's important for the students to talk to the surgeon and be making what the surgeon wants to use. Important to try it in, important for us to make sure it's fitting properly, and important to check with the radiograph that things are oriented properly. So these are the steps that most cases will follow to restore a single tooth. They should know that prior to their patient coming in, they need to have some parts ordered. So they should be able to go to the chart and find a sticker that was placed the day of surgery, hopefully, so that they can find out the size of the implant and whether it's bone or tissue level. They can obtain a catalog from the dispensary, or they can use my little condensed list, and Deb brought copies of those up here, but these are down with all the dental assistants in their stations. And so they'll need some assistance to fill out their order form, and we would sign it. So they'll need initially a fixture level impression coping and an implant replica. Looking for the sticker. And so again, this is from one of their lectures. We talk about the function of the fixture level impression, that it's either to generate a cast to make the restoration or to select an abutment. Dr. Brewer brought up a point to me the other day, noting that there are times when the opposing tooth may have shifted or super erupted, and you want to maybe consider routinely making a new cast of the opposing dentition when you're about to start the restoration, or at least take a look at it and see if anything seems to have shifted, because that can cause some problems. Most of the time working posteriorly, we're going to be doing closed tray impressions. Again, this is from one of their lectures explaining what an open tray impression is, and again, we're not doing these downstairs all that often. This is the Straumann tissue level, or I'm sorry, bone level, fixture level coping. And you want to be careful, especially with the bone level implants. When you take the radiograph after things have integrated and you see that this is where the platform is and that you have bone here, you really have to be careful that your components are seating properly. So that would be one of the circumstances where for sure you'd want to take a radiograph before you make your impression, make sure things are seated. You probably know that you can kind of feel if the coping is binding as you're trying to screw it in. So usually I'll unscrew the coping a little bit and screw it in myself just to get a feel for whether it seems to bind, because that kind of clicks in my mind that I'm having trouble seating it all the way. So just, be aware of the situation, and if it's warranted to take a radiograph, do so. If you're using the tissue level and you're using those plastic components, then obviously there's no reason to take a radiograph because you're not going to see anything. So our fixture level cast is the working cast if we're making a screw retained restoration, or we use it for abutment selection for cement retained restorations. If we're going to make a screw retained restoration, and again, we make some assessments with, in terms of how much restorative space we have. We have those kits. I'll get to the kits in a minute. But we have little try-in kits in the dispensaries that have plastic abutments that you can try in and physically see how much space you have. I find that helpful because that measuring is kind of difficult. But basically what you're going to do is order a waxing sleeve with a gold alloy base. You'll shorten it, and it's really a good idea to try, well, I'll show you what I will recommend here. This is the component that you would order. This is what it looks like. You would cut it down, and it's not a bad idea to either do this yourself or have the laboratory start to make a pattern for you and then go back and try it and make sure your working cast is accurate. There have been a number of circumstances over the last year where there have been some issues with that. One thing you can do is try that in the mouth and make a little jig out of bite registration material, and then if this fits back onto your cast like this, you have an accurate cast to work from.
Jennifer, some of those abutments are milled, scanned, right?
You can't apply porcelain to them, though. These are cast too.
I know, but I'm just saying, I have, well, never mind, maybe I'll do it.
So then you can set it off to the lab to be cast and have porcelain applied. So why are we getting excited about the accuracy of the cast issue? And this came up last year. There was discussion about, well, why don't we just put the abutment on the cast and then make the crown on the abutment on the cast? And you certainly can do that, but if you do, you darn well want to make sure your cast is accurate first. This was a case that was transferred last year, and the student passed off the fixture level cast that she had made, and so the student then decided to work with me, so we waxed up and scanned some custom abutments, which you see over here, which we then tried in and saw did not remotely fit. And so I had her make a new fixture level impression, and those casts look like this. So this student had messed it up on, there were two abutments in the same patient, one on either side of the arch, and both of them were inaccurate. It looked like she hadn't seated the impression coping and replica all the way into the impression for it to come out like this. So we had to make two more abutments. That does happen. And then this is one of my patients, and this is stuff I do fairly routinely, and this is the wax up on my cast, and I had it scanned, and that's how it fit in the patient's mouth. I made a new fixture level cast, so I hadn't seated it all the way, and I made a mistake. So for a cement retained restoration, you need to consider how much interocclusal space you have, how much soft tissue depth you have, angulation, whether it's centered. Prefabricated abutments are best when the implant is centered well within the space, and you have a uniform tissue depth all the way around. And again, you're going to base your selection on tissue depth, Burgess profile, angulation, and interocclusal space at varying axial wall heights. And again, these are the kits the students can sign out in the dispensary. There's one for the tissue level implant and one for the bone level implant. And you can take these little parts out and stick them in the cast and hold your cast together and say, yes, this will work. In my mind, it works easier than trying to guess. So that's what that looks like. What you need to be aware of, however, Yes, the order numbers that you see on the box are for new plastic parts, not for the actual abutments. So I think we're doing more bone level implants than tissue level implants, but I'll just kind of go through the tissue level quickly here. Most of the time you'll probably be using their solid abutment. It comes in 3 heights for the regular neck, 4, 5.5, and 7. For the wide neck, it's 4, 5.5. So these are the abutments. They come with their own impression components. When you order one of these prefabricated abutments, it's a good idea to order one of their what they call all-in-one kits, because it gives you the abutment, it gives you the abutment replica, it gives you the impression components for the abutment and the waxing sleeve all in one. So it's kind of a no-brainer. You don't need to worry about ordering anything else. Everything you need is there. For the bone level, most of the time we're using the cementable abutment. And to me, this is a little trickier because you also have to add in the variable of the tissue cuff. But basically, you have 2 different heights, 4, 5.5. You have a couple of different emergence diameters to choose from. And then again, multiple tissue cuff heights, 1, 2, 3, for each of those. So that's why that try-in kit is kind of handy to try some of these in and kind of see what's going to work the best. And these come in all-in-one kits also. So when you've selected the prefab abutment you want to use, you fill out that green order form. And again, if you don't want to have to worry about ordering all the parts you need, just get that all-in-one kit, and then you sign it and it goes to Deb. Custom abutments, we make a lot of them here, usually because of placement errors, but it can be something a lot more subtle, like having your tissue level not at the same depth all the way around the implant. So it allows us to compensate for unequal tissue depth, put the finish line in a better place. This was a patient who came to see me who had a tissue level implant placed bone level and beyond. And this whole thing is the crown. It was placed on the solid abutment, and so there was cement and all kinds of crud down here, and the crown wasn't seated all the way. So obviously that wasn't a good idea, and this still isn't a great scenario, but this is what you would do to place the finish line in a better place. So if you're going to make a custom abutment, these are the components you're going to order. This first one is for the tissue level, the others are for bone level. And you can do one of 2 things. You can either trim your soft tissue model appropriately and submit the pattern to the lab to wax up for you, and then get it back and check it and send it back for milling. Or if you are knowledgeable in this, you can assist them in waxing it up yourself and then submitting it to be milled. So we do much of this here. You can either fabricate something in titanium, which in the posterior areas is mostly what we do, but if you have a patient with a high smile line and you're doing a first premolar, you certainly can use zirconia. Abutment insertion. One thing I try to be aware of with students is remembering that the last time they used all of these little screwdrivers and little parts was back between their 2nd and 3rd years of dental school, and most of them are now in their 4th year. And these are all really tiny parts, and you know how you fumble around with these things the first time. So I spend some time kind of showing them how to best position the patients so that they can kind of have control over the situation, and telling them to use throat screens and things like that is a good idea. But trying in your abutment, review with them how to use the torque wrench properly. They are taught to torque it twice, 10 minutes apart, because of the preload concept. Somebody was asking me if you can do it once, one visit, and then do it the second time the second visit. Yes, you can. It has to be at least 10 minutes apart. And you should write in the chart that you torqued it twice to 35. So again, that's one of those all-in-one kits. It's got the abutment replica, impression components, and your waxing sleeve. So you'll assemble the impression components. It also has a basket and a positioning cylinder. And the important thing you have to remember with the solid abutment is that this is a one-piece solid abutment. There's no screw and there's no thread timing. So you have to place that abutment and you have to torque it twice before you make your impression. If you torque it once and you make your impression and you torque it again and that thing moves a little bit, you've just created an inaccurate cast. All right, so these are designed to go in the mouth and stay in the mouth. You must torque them before you make your impression. So just showing the placement of the abutment and torquing it, and how the impression components fit. You place the basket and then the positioning cylinder. And then you're going to insert an abutment replica into your impression to make your cast. The solid abutment absolutely has to stay in the mouth, as I said, and therefore you need to make an interim restoration for it. I always encourage students to try to do it on a cast. Now, if you're doing it for a solid abutment, you're probably going to have to make a shell that will be relined in the mouth, because again, you're not going to have the thread timing correct if you just screw the abutment onto the cast, or you may not have it correct. But as you know, it's very easy, because how often in the mouth is there a nice papilla there? There's usually a big undercut under the adjacent tooth, and it's very easy to lock integrity or PMMA in there. So it's a good thing, a good exercise, I think, for them to block it out on the cast and at least start it on the cast. And it gives them the opportunity to make the best margins possible. There's a temporary coping that you can use. Personally, I never do. You don't really need it, but it's there if you want it. But it gives them the opportunity to make the nicest margins ever, because they can just seat the thing on their abutment replica and kind of tune them up, polish it up nicely. Now, the exception to inserting the abutment on a tissue level implant and leaving it there is the Synocta abutment. So if you choose one of these are designed to go on the cast and have the crown fabricated on that cast. So these do not go in the mouth until you're inserting your crown. Personally, I don't really use them. I think I used one of the angled ones once. And they come in multiple angulations that you can select. And if you're using an angled one, it's especially important for you to try it in the mouth and make sure your cast is accurate. And important that you transfer how you have it oriented ideally on the cast to the mouth. Otherwise, you're going to be fumbling around and having a hard time getting it, because there's something like, I don't know, 8 or so different positions that can be in, maybe more. So again, it's kind of important to try this in, make sure that what you have on your cast is accurate before you go and have your crown made. Cementable abutments kind of follow along the solid abutment concept, except it's 2 pieces. Again, you're going to insert your abutment. They've got a plastic component for making an impression of it. They've got abutment replicas that you snap into your impression and fabricate your cast. When you make one of these casts for a prefabricated abutment and you're using an abutment replica, the student does not need to Pindex that, but they should pour a soft tissue model. Now, the waxing coping that comes in that all-in-one kit has to go to the lab. If you don't send it to the lab has to order them, and then when the lab orders them, we have to pay for it, versus when Deb orders them through the school, we don't pay for them. So use the ones that we get for free instead of having us pay for new ones. So these kind of become the foundation for the crown that's cast. It's important, I know our technicians know this, but you need to tell your student that when they're communicating with a laboratory in the future, that you don't want them casting that little thimble as the substructure for their crown, because how many times have you seen this from inadequate metal support over these prefabricated abutments? All right, so it's important that they send their wax up to the laboratory, they can index it, they can wax in appropriate support for the porcelain. Custom abutments, we insert and we treat like teeth. So you'll pack retraction cord and make your impression. You will pour your model, you'll Pindex, you'll ditch them, and then mount and submit to the lab for crown fabrication. So again, if you're using an abutment replica, you don't Pindex it, you pour a soft tissue model. You may, if needed, have to trim that soft tissue model depending on the circumstances. Okay, so your mounted cast, your diagnostic wax up, your waxing coping, all goes to the lab with your prescription. Now, this is a slide I used in one of the lectures trying to demonstrate the difference between restoring crowns on teeth versus implants, and knowing that implants are not as forgiving as teeth are as we're trying things in, because they give much less. It's much harder, as you know, to adjust interproximal contacts. You know, very often we have these very long, broad contact areas, and we have, especially here where you have multiple adjacent rigid implants, it's very easy to go from having way too much contact to none. So these are all, this is a patient who came to me, and she's not having any problems with these, but every single contact is open, and I'm not sure what's going on down there on the lower right, but in any event, and this is one of the reasons why we separate those adjacent restorations for students, because it's much easier for them to manage one at a time. Be particularly careful if you're trying in a screw-retained restoration, if you're like me and don't do these a whole lot. I was getting lazy. This is one of my own cases, and I didn't want to have to screw that thing in every time I tried it in to check the interproximal contact, so I left the screw out and I'm adjusting and I think I got it, and then I said, okay, I'm going to screw it down and just do a last check. Well, I had opened the contact too much, and it doesn't look like it, but I had opened it, so I had to send it back to the laboratory. So it's kind of a pain, but you should screw the thing in every time you try it in and check it. They're taught how to properly adjust the occlusion. It should mark articulating paper, the crown should. However, the natural dentition should resist the shim stock, and the crown on the implant should not. And if there are considerations for lateral guidance, you want to consider those as well judiciously, probably make it fairly shallow. So again, we have to kind of watch them carefully with the interproximal contacts. They are taught how to properly adjust the occlusion. There is shim stock paper on the clinic floor. Whatever is appropriate in terms of excursive contacts, and we use permanent cement. All right, so typically here that constitutes either a glass ionomer or Fuji Plus. And I think the cementable abutments have a screw channel. You can either have them place a cotton pellet and firm it, or I think, are we getting Teflon tape, did you say? We will have Teflon tape available if you want to use that. But if there's a screw, then you should block it out before cementing. Any questions on anything?